0.
Good afternoon and good morning, dear colleagues. I'm very pleased to welcome you at our session today that is devoted to health sector reforms. We have organized it in two parts. The first will discuss health sector reform from the perspective of one country, Ukraine, that has gone and still is in the process of massive health system transformation. And then in the second half, we'll talk about the future of reforms, discussing various health systems enablers and accelerators. I will be moderating the first session. My colleague Veres Lidar will take over and facilitate the second session. So my name is Nata Avaliani. I represent Deloitte Consulting, and for the past 6 years, I was actively involved in the Ukraine reform through the USAID Health System Strengthening projects. I'm very pleased to introduce our speakers. They represent USAID Health Reform Support Project that is a partner of Ukrainian government, the civil society and other stakeholders providing assistance in various components of health sector transformation. So our speakers today are Alexei Yeremenko, Deputy Chief of Party of the HRS project, who will speak about the policy reforms. Then Vlad Adrinsky, the Senior Technical Advisor for Service Delivery, and Jack Bessay, the Senior Technical Advisor for eHealth, will take over and will focus on the reform implementation mechanisms. Our final speakers for the session will be Elizabeth Villarreal, Chief of Party of the HRS project, and Paola Pavlenko, Senior Health Advisor at USAID Ukraine. They will discuss the lessons learned and challenges the country is facing ahead. So I would like to ask you to please write your questions in the Q&A format, and we will respond to them during our session at the end of for the discussion. Thank you very much. So I will start first with the context and factors that triggered health system transformation in Ukraine. So a little bit of background: Ukraine is located in Central Europe and is the 8th largest country in Europe. Since its independence from the Soviet Union, the country faced many health challenges, largely due to the heritage of the healthcare system and various political, social, and economic factors that continue to influence country's development. Here are the few characteristics of Ukraine economy and healthcare, comparing with neighboring Poland and Estonia, who share similar historical development with Ukraine. So Ukraine's per capita GDP is more than 2.5 times lower compared to Poland and 3 times lower than Estonia. The government expenditures on health are substantially lower compared to EU average. So subsequently high are out-of-pocket expenditures. One of the biggest problems of Ukrainian healthcare are widely accepted informal payments. 48% of patients pay informally for primary care services. Over 70% of patients pay under the table for essential services in hospitals. So as you can imagine, this results in poor health outcomes. Life expectancy is almost 10 years lower compared to EU average, and particularly the life expectancy in men is among the lowest in the region. Lack of political leadership and implementation resulted in no major reforms in 20 years. This led to continuous challenges and failures of the healthcare system. There is fragmented multiple-tier financing system. It is centrally planned and organized inefficiently. Funds are collected through general tax and were distributed from the central level to regions and districts. Provider payment system was input-based, so healthcare facilities were paid based on the number of beds, personnel, and population, stimulating oversupply of services and inefficiencies. There are many beds and many hospitals, which is a result of input-based budgets, poor gatekeeping, and also frequent self-referrals to secondary care. Mostly publicly owned healthcare facilities lack modern technologies and equipment, which is due to a lack of competition and investments. As we said, inefficient resource allocations for the declared free medical services results in under-the-table payments, causing inequity and a lack of access to essential services. There is also a non-transparent and corrupt procurement system for medicines and supplies, which resulted in limited access to essential medicines for many Ukrainians. So poor quality of care at many levels is also characteristic for Ukraine and is due to the lack of evidence-based practices, modern technologies, and infrastructure. And corruption and informal payments are also widespread in medical and nursing education, resulting in poor training and a lack of continuous professional development. In human resources, there is also limited modern training programs for healthcare managers, epidemiologists, and public health professionals, resulting in the lack of skills in healthcare financing, public health, and healthcare administration, which are so essential for health system reform. So in 2014, the Revolution of Dignity triggered public demand to eliminate corruption in healthcare system and to consolidate efforts towards integration with the European society. The reform launch was a joint effort of the government of Ukraine, the civil society, and it with very active engagement of patient community. Many international partners and donors provide technical assistance to the government of Ukraine to help the reform succeed. So the National Health Strategy was approved in 2015 and prioritized healthcare financing and public health system strengthening reforms. The key legislation were launched. They introduced healthcare provider autonomy and new governance principles for healthcare facilities. The program of medical guarantees, it is the first time in Ukraine, it has defined the benefit package of medical services. The new legislation, also first time, allows access to government funds for private healthcare providers, stimulating private sector engagement and competition in healthcare. The several key national institutions were established, starting with a single national purchaser called in Ukraine the National Health Service of Ukraine, the Center for Public Health, and the Central Procurement Agency. All these changes created opportunities to advance and accelerate health reforms, to eliminate corruption within the Ukrainian health system and improve availability, access, and quality of healthcare services. I'll stop here and give floor to my colleague Alexey Romenko, who will now continue and will talk about how the reforms unfold. Alex, to you.
Good afternoon. Based on WHO 6 building blocks of health system, National Health Reform Strategy for Ukraine 2015-2020 was prepared as key document with clear goals, objective, and implementation plan. Starting this time, Ukraine health system under reforming, including leadership and governance, health financing, workforce, service delivery, information system, and access to essential medicines. It is important to note that the transformations are comprehensive and not fixing small problems, but creating new models and solutions. Let's start with leadership and governance building block. At the national level, a central executive body, the National Health Service, has been established. The NHSU responsible to implement state financial guarantee for healthcare services for population as single strategic procurement of health services. In line with European practices, government role in healthcare was clearly defined and limited. As a result, Ministry of Health was reprofiled away from operational functions such as medical procurement, hospital operation, facilities maintenance, and concentrate on policy making. It's in parallel with the implementation of health reform in field of medical procurement, public health, and development of electronic healthcare system, appropriate bodies were created from scratch. It includes Center of Public Health, Medical Procurement for Ukraine, and state-owned enterprise eHealth. In order to coordinate the activities of healthcare providers in each region, hospital council have been established which are responsible for ensuring network optimization. Significant changes implemented in service delivery. Public health care providers got autonomy in three main areas: financial management, personal delegation, and service development planning. It impacts hospital efficiency, use of hospital care, and better management. To address universal coverage, in 2018, Program of Medical Guarantee was introduced. All public resources to implement Program of Medical Guarantee accumulated under a single-payer National Health Service of Ukraine. To improve efficiency with the health finance reform, Ukraine moved away from input-based financing. In parallel, a new payment mechanism introduced, using the key principle, money follows the patient. NHSU funds services at the primary healthcare level with capitation payment mechanism. In specialized and hospital care, global budgets are used in parallel with fee-for-services and case-based payments. Despite such short period of time, after the introduction of new payment mechanisms, we see an improvement in quality of medical services. Starting from primary care level, several principles have been implemented. First of all, free choice of family doctors, and now it's not limited to location of residence. Second, family doctors are able to open a private practice. Third, the capitation payment mechanism introduced. And the most important, that family doctors start to implement real gatekeeping function in authorizing access to specialist care and diagnostic. It's important to say that Ukraine has an oversupply of facilities providing inpatient care. I'm sure you understand how difficult to optimize hospital network. To address this issue, government of Ukraine used different strategies. It includes developing of hospital master plans, introducing new payment mechanism, selecting hospital for strategic investments, reprofiling hospital, addressing inappropriate admissions and improving outpatient care, establish specific criteria during contracting with the National Health Service of Ukraine. Another very important building block is access to essential medicine. It was decided to use health technology assessment as an instrument for decision-making. It's already pilot for drugs inclusion in essential medicine list. After the essential medicine list was introduced, healthcare facilities are required to procure essential medicine before anything else, which reduces corruption by reducing unnecessary procurement volume and value. In a short period of time, Ministry of Health reported that the procurement by volume reduced by 9% and procurement by volume increased by 14%. Medical procurement always was a big part of corruption area. Starting 2016, state medical procurement passed to international organizations like UNICEF, UNDP, Crown Agency. In parallel, it was decided to build a national procurement institution called Medical Procurement of Ukraine. All this led to a significant reduction in the cost of drugs and decreased level of corruption. In 2017, drug reimbursement program was launched. This program covers free essential medicine for treating 4 diseases. Family doctor issue electronic prescription. With it, medicals can be obtained at any pharmacy. The program helps to reduce personal health expenses of Ukrainians. In parallel with the implementation of the healthcare financing reform, Ukraine has begun to develop a unified health information system. Reliable information is a foundation of decision-making across all health system building blocks. E-health architecture is open up opportunities for public-private partnership. The government defines the overall e-health framework development, coordinates central database, data security, information exchange, and other parameters. Private developers are responsible for medical information system building. It creates opportunity to introduce innovations and promotes business environment. Development of e-health goes in line with the health reform. It starts with signing declaration by patients, the immunization program, medical referrals, medical records, and so on. It ensures transparent funding mechanisms for healthcare and improve transitions to electronic accounting in the healthcare facilities. The health workforce is the most difficult area for health reform in Ukraine. There are still more plans in this area that have been implemented. However, today we have clearly understand the scope of work and challenges and tasks that remain to be accomplished. Government of Ukraine developed the medical education reform strategy. New profession and education programs have been introduced, like public health and health managers. The health workforce planning process have been launched. We expect that in 1-2 years, all regions will have clear plans for implementation. This will impact on management and deployment of the health workforce to meet population needs across urban, rural, and remote areas. In parallel, it's planned to introduce National Register of Healthcare Workers. During last significant donor resources are spent on strengthening comprehensive skills, knowledge in a health workforce, including training of medical workers according to international standards such as DOADECA. All this improves quality of medical care for the population. In next year, it's planned to introduce individual licensing and strengthen role of professional association. And now I'm passing the word to Vladislav to present health reform implementation and system transformation.
Hello, everyone. The scale and speed of healthcare reform implementation requires strong communication with all stakeholders. To raise awareness of health reforms, the government conducted outreach and communication campaigns to the public, healthcare providers, regional authorities, and other health sector stakeholders. Communication include with USAID HRS project support, the government conducted 4 health reform information tours that were tailored to explain and promote the following stage of reform. Stage 1, launch of health system transformation. Stage 2, lead up of primary healthcare facilities to transformation under new program of medical guarantee. Stage 3, lead up of secondary healthcare facilities to transformation under new program of medical guarantee. There was very high risk of postpone the stage of health reform. Information tour reached almost 5,000 healthcare professionals, local governments, media, and NGOs through 47 events. It was crisis communication resulted by a timely launch of new stage of reforms. Stage 4, support of healthcare providers in PMG implementation. Many activities of fourth tour were virtual because they took place during the pandemic. The success of these communication campaigns is to involve both healthcare providers and people in the transformation of the healthcare system as its users. 74% of Ukrainians, more than 30 million people, signed a declaration with family doctors during the first year PMG launch. Almost all healthcare facilities have changed their status to non-profit enterprises, joined PMG and signed contracts with NHSU in a timely manner. 2.5 million Ukrainians, most of them elderly, use the affordable drugs program. The challenges that accompany the transformation process are health system resistance and short policy cycles with a change in the directions of reforms. Lack of one voicing because of political stability and anti-corruption core of health reform. Lack of government capacity to conduct communication campaigns, tours on their own, leading to overlines of donor community. And given the above, this an ongoing need for crisis communications. The implementation reforms requires a review of inpatient care. Soviet era service delivery model with input based budgeting for healthcare facilities resulted in a high number of hospital beds and high average length of stay in hospitals. The quality of care provided at many Ukrainian hospitals is often inadequate because also there are many services due to the lack of essential equipment and or adequately trained personnel. Through the health reform, money follows the patient principle. the government would pay hospitals via the NHSU per case treat. This requires hospital networks to restructure in order to meet service requirements and achieve financial sustainability in the reformed payment system. Within health reform agenda, hospital districts were created across of Ukraine, and every hospital district must have the medium-term development plan. They complete the hospital district development plans to guide this restructuring. The HRS project supports all regions in modeling hospital networks, using facility-level data and international benchmarks to determine which hospitals should become acute care hospitals, where resources should be directed for further development, and how patient pathways should be adjusted. Successful piloting of the hospital planning methodology in the Zhytomyr region allowed to begin its spread to all regions of Ukraine with the support of the Ministry of Health, NHSU, and the Ministry of Regional Development. It should be noted that in parallel with the healthcare reform, there is an administrative territorial reform in Ukraine. Under Ukrainian law, healthcare facilities are owned by communities. The centralization reform brings new challenges for the local authorities as to how effectively manage health network based on evidence-based and bottom-up approach. Lack of the vision and strategic planning for healthcare network on local and regional levels is an obstacle for the investment attraction and the effective allocation. Outdated legal framework for different models of cooperation and management of healthcare facilities needs to be updated. Lack of reliable health data include facility-based health data, epidemiological data, and forecasts. Needs a rapid introduction of information technology on all levels of healthcare system. Strengthening primary healthcare is the basis of the modern healthcare system, and it has become one of the key pillars of health reform in Ukraine. Ukraine's Soviet inherited healthcare system was organized around the system itself. Primary healthcare providers were often the least equipped with resources, tools, and training. PHC centers contracted with NHSU requiring legal change to non-for-profit enterprises, computerization, and patients signed a declaration with the family doctors, introduced capitation-based payment in primary healthcare to shift attention to the patient and improve quality of care. During the reform, there was an urgent need to change the organizational culture of the healthcare system to better serve patients, develop patient-centered care and communication skills of doctors and nurses. To improve quality in primary health care for facility and provider strengthening, HRS project have developed the concept of centers of excellence for the Ukrainian context and implemented selected primary care facilities. HRS also increased the involvement of civil society, patients, creating boards, patient satisfaction surveys, etc. Among the success can be noted facilities complete necessary hardness to contract with NHSU. Now all public primary healthcare facilities contracted with NHSU. Engagement of private providers, in fact, of more than 1/3 primary healthcare facilities contracted with NHSU are private. Increasing patient satisfaction. Within the centers of excellence, patient satisfaction increased to 95% compared to the national average of challenges that remain: no quality monitoring system, no performance-based financial mechanism yet, but is planned for development this year. No formal process structure to engage medical professional association in quality decision. As we mentioned, information technology and health data are the basis of healthcare decision making. So for the next part, our presentation will be about this, and I pass word to my colleague, Jack Visi.
Thank you, Vlad. As we discussed, Ukraine is transitioning from a paper-based health system to an electronic health system in order to increase transparency, accountability, responsiveness, and efficiency. Enabling the health financing reform, the e-health system will capture patient, provider, and health service data to provide payments and manage records. The e-health system is seen as a tool to support and facilitate the healthcare reform efforts. As you can see from the timeline, the technology moved forward with the health reform, and lots of transformational changes have occurred in a very short time. Here we've highlighted them, health reform changes in gray, and blue, those more directly related to the e-health system. Through the HIV Reform in Action project, USAID developed the e-health minimum viable product to support capitation and reimbursement processes. By the end of 2016, the e-health MVP connected over 1,300 healthcare facilities through 13 medical information systems. And the HRS project continued supporting the Ministry of Health, National Health Service of Ukraine, and e-health state-owned enterprise for the further development and implementation of the e-health system. By 2020, the e-health system had over 30 million patient declaration and was connected to over 3,000 healthcare facilities. While largely successful, the rapid advance has led to some issues and areas we can look to improve upon. It has required us to be very deliberate in setting up foundational pieces that ideally, and in theory, would have been there in the first place. During the formation and launch of the health reform, technology was always seen as a key to increasing the transparency and helping reduce corruption. Because of this, there was a lot of pressure and effort to produce technology solutions quickly, again, in line with the reform and to support each step of the reform. However, looking back at the efforts, it is apparent that good foundations of software development and strong processes should be in place to also support future reform efforts. For this, we focused on 3 areas. People. While technology is often seen as the answer, it is really just a tool to enable people to work more effectively and efficiently. Therefore, one of the keys to cementing the reform is building the skills of the people involved with the process. As Ukraine moves towards a digitized government and looks to have many services placed at the fingertips of their citizens, we needed to look at the level of comfort and skill the population, providers, and administrators have with digital technology. Obviously, the skills required are very different for an administrator than a private citizen, but each has a role to play in the health system, and therefore the skills like good digital hygiene, protecting your password, to cyber skills like ethical hacking for penetration testing, understanding and remediating vulnerability reports are all key. Processes. These processes are vital and should continue to enable the reform, not hinder it. The technology should roll with the reform as we move forward. Their presence can really help it when it comes to orchestrating such an important effort. In Ukraine, you have multiple government stakeholders, MOH, NHSU, SOE, the Ministry of Digital Transformation, donors, and other implementing partners, private companies, and other government initiatives, all trying to help achieve the goals of the reform. Absent clear, effective policies and procedures, you run the risk of duplicating efforts, paying for overlapping capabilities, in essence, doubling the cost, and potentially having resources spent on competing priorities. Software and hardware. So as we continue to push the reform forward, it is important for us to take stock of what we have accomplished and also drive towards good sustainable practices that will reinforce the system and the reform. We've done this by working with our counterparts to develop a comprehensive architecture for the system, build and roll out SDLC processes, and work on enhancing the cybersecurity posture of the system and our agencies. Especially when it comes to digital or technologies, these are not one-time discrete events. This is an ongoing iterative effort. You need to continually be adapting to new tools, new threats, new laws, new resources, new people, new opportunities, and emerging technologies. You build the foundation and then continue to layer on the new tools, technologies, and techniques. But at the same time, just as with your home, you need to maintain that foundation, the building blocks, SDLC, architecture maps, concepts, roadmaps, strategies that are all tied into policy documents, help you avoid duplication of effort and other missteps that can squander limited resources and derail reform or transformation momentum. And with that, I'll turn it over to Elizabeth and Paula Pavlenko.
Thank you, Jack. As you have heard from our colleagues, the implementation of health reform in Ukraine is still an ongoing process. We would like to now close the first part of our session by summarizing high-level lessons learned into these three general buckets. The first is the importance of quick adaptation. Like in many countries, the building while flying the airplane approach is unavoidable. Adapting quickly as the operational and political environment changes is critical in order to not lose momentum. What we have seen and experienced is that while plugging gaps is important, by staying responsive and making tools and procedures available quickly to those implementing the reform, it is equally important to balance this out with evidence-based policy changes.
And also, as you can see from the previous speakers' presentations, some key guiding documents such as kind of national health strategy, e-health concept, implementation road and architecture maps for the e-health are vital to create a sustainable building blocks for the future of the reform. And as we say, we are now only embarking on the next stage of the national health sector strategy because the current one just expired in December 2020. And also, while we are good with e-health concept, just recently developed by multi-sectoral approach and with many stakeholders, it just been approved at the end of December last year. And the implementation, action plans, and architecture things are still ahead of us.
Thank you. Second, perception is reality. Building resilience at the base so that any shocks to the political and operational environment can be withstood is important in order to bring all tiers of stakeholders along the reform path. Building a knowledgeable health consumer may not seem as critical when reform priorities are being rolled out. But creating this resilience at this level ensures that a solid foundation is built as policy changes continue to adapt to new reforms.
And here we must say that the communication campaigns not only need to be multi-pronged and multi-layered and multi-tiered, but also have to be very creative to engage a very wide audience, from policymakers at the national level, at the parliament, for example, to the kind of local level at the county and municipal levels, to healthcare providers, also to patients and educators and private sector. And the important here is building trust through awareness, but also to being very open to accept the feedback and learn from it, and most importantly, act on it. And we have to say that currently the health reforms remain very highly contested area with very much competing and sometimes controversial and sometimes inconsistent views. From the very recent survey, which was done in April 2020 by local and international experts, they showed that despite more than 52% of Ukrainians who felt negative impact of healthcare reform so far, still more than 55% of them still think that the government should continue health reform, of course, with some adjustments to be made.
And third, coordination is an art form. It is important to make coordination deliberate and remember that reform does not happen in a vacuum. As mentioned by Paula and our colleague Vlad as well, While there is always a lot of will, the reality of schedules and competing priorities, competing reforms like the decentralization reform mentioned and others that are concurrently happening, plus the natural transition of personnel within the government, donors, partners, coupled with major shocks like the one that we saw this past year with COVID, make it all the more important to get creative about how to integrate coordination into the feedback loops that inform decisions by all stakeholders. Health reforms have come a long way since 2014 and are far from complete. The next steps are going to be critical to ensure that all Ukrainians can access high-quality healthcare without bribes or catastrophic out-of-pocket payments. So now, looking forward at the national level, we see the need to further bolster structural guiding documents. These guiding documents are critical in order to keep all stakeholders accountable, and in particular, moving in the same direction. This includes continued support for governance, like Paula mentioned, a national health strategy that expired at the end of last year, build outs to the e-health concept and the public health law. These structural guiding documents will reduce false starts, the potential for corruption, and reduce opportunities for malign actors to discredit and harm the reform.
As we look forward to at the implementation level, we know that kind of working out the bugs in the implementation will be hard. It's a hard work. But we see those challenges also as opportunities, and we see the kind of the chances to address such issues primarily in the three big areas. So one of the area is kind of workforce planning, where we should look at optimizing task shifting, for example, for the nurses. It is especially critical with the additional COVID burden, for example. Also revitalizing efforts for the medical education reform implementation. Another big area is the private sector engagement, where we should look for the role of private sector. And there's a great need in increasing and improving private sector engagement by creating new partnerships, attracting investments, and also connecting business to government to find solutions to policy and implementation problems. One good example was also given by our colleague Jake Wessey in e-house area. It's like a sandbox where kind of the businesses and the government in face of the Ministry of Health and National Health Service can experiment with some IT solutions, creative solutions to solve problems of the patients and the doctors in telemedicine, for example, which is again especially important in the COVID era. And the last but not the least is the area of quality improvement. Whereas we moved forward in financing and e-health, quality improvement is still the area which really we have to build out monitoring functions, increase the kind of public financing management, introduce performance-based funding, and also engage professional association to kind of to be more of a watchdog for quality, and also be part of the bigger role in managing hospitals as an independent entities now to serve on the boards to be really in the front of this fight for quality. Over to you, Elizabeth.
Thank you, Paula. Two additional areas that we also see as important looking forward at the implementation level are the creation of a culture of data. So increasing quality data inputs in order to arm leadership at all levels with quality data for decision making, and really being able to use that data responsibly. Additionally, as you've heard from the majority of our colleagues, and in an increasingly digitized world, looking at the benefits of a thriving e-health system, while acknowledging the importance of safe and efficient principles for digital development, such as interoperability, cybersecurity, and data security. There's a lot of challenges, but we also feel like The path forward is full of opportunities for the reform in Ukraine. Thank you very much to all of you for joining us today. We will now move into the questions and answer session. Over to you, Nata.
Thank you very much, Elizabeth, Paola, and I want to thank all of our panelists for this very comprehensive overview of very complex reforms that took place in a very high speed, high pace. And I think there are many, many lessons learned from these reforms, both for Ukraine in their future steps, but also for many good lessons learned for application globally. So I would like, first of all, to encourage all our participants to use the Q&A format and ask us questions, because, I mean, as you heard, there is a lot to say. We did it in a concise format, but I'm sure there's a lot to share more and talk more about this reform. So maybe I'll kick off our discussion with a question that I think maybe she'll be interested for many. And at least for me, I think it's a very important question to consider, is that where do you see were major barriers to reforms and to its implementation? So maybe I'll ask with Alex to cover this for us.
Yes, thank you, Nata. And I will start with some lessons learned from health reform implementation. So based on our experience, some barriers could potentially influence on the lack of leadership at national and local level. It's always very important to find the leaders and persons who will drive the reform. Second issue, it's limited limited resources investments, including finance. As you understand, it's very difficult to conduct and implement reform without funding. And so before moving forward, you should be ready to invest more resources and bring public finance to the health reform. Next barriers is resistance from the medium level management and some doctors. So here, in this case, strong communication campaign should be provided and should be focused to address all questions and issues and avoid as many problems as possible. Next barriers could be mentioned is a lack of information technology. Some changes related to health reform will require IT solutions, and it's very important to synchronize IT development and reform processes. Next one, it's limited number of high-quality managers at specifically at public hospitals. So extensive education programs should be implemented in different levels at universities, at trainings program, and so on. Another important observation is related to the implementation process. To implement any changes, you need to train staff, and this will take a significant amount of resources and time. People should understand what will be the new requirement for them, even in providing care services in finance and management. So these resources should be adequately planned and should be investment to drive the reform. But it's based on experience. But if we are thinking about further development of the reform, very important to have a clear plan. For now in Ukraine, there are no long-term plan. It's a quite big risk for the furthering health care reform. So preparation of such document will require coordination action between government of Ukraine, public sector, and international community. So the lack of such plan doesn't allow doctors, administrations, and patients to understand the next steps in the reform. And some policymakers can use this situation to provide disinformation and bring unnecessary barriers to implement further steps. So one comprehensive plan, as was provided in the beginning of Ukraine health reform, need to be developed soon.
I'd like to just add 2 points to Alex's points about barriers. I think it's important when talking about the technology to also keep in mind the digital divide. So making sure that as technology comes online, we're being conscious of the fact that we need to have all of this technology be inclusive of a larger population that may not have access to all these tools. So understanding what those gaps are and making sure that everybody is able to access the same level of care at their fingertips. And then the second is, one big key barrier that was highlighted in the changes that have taken place during the reform is behavior change. So this is a very complex change that is taking place that's also linked to the medical education reform, and changing how medical personnel provide care and center this care to the patient is something that is new here in Ukraine, and will take some time to get rolled out very comfortably with everyone. I think older generation doctors may have a little bit more trouble, as we've seen, but we're hopeful that with a variety of different training and support and the other reforms that are taking place around the health financing pieces, it will help push this behavior change along as well.
Thank you very much, Alex, Elizabeth. This is a very important. These are very important insights. Again around this barrier question, we talked that the corruption and informal payments ingrained in the system are one of the biggest challenges for the reforms. So, and probably the biggest barrier is to change this culture of informal payments existing for so many years. So, Paula, maybe you have some ideas to share with the audience, and I'll talk a little more about this topic.
Thank you, Nata. I probably will be very quick because there may be some other kind of people wanting to ask questions. But I think the issue on what to do with informal payment, or what in Ukraine we often call bribes, have two sides. Those people who take, these are doctors and nurses and medical personnel, and patients. There's kind of patients who give. And from the medical personnel, in addition to behavior change, is also, of course, the salary level have to be increased. Because the low salaries, this is the ground for people kind of asking for and waiting for the informal payments from the patients. And this is the area where kind of the government with the National Health Service is really thinking hard how to do it, how to increase tariffs. But it also should be coupled with the quality and, of course, with the ethical standards, with professional associations being here as big player. On the patient side, I think kind of patients should know their rights. And at the moment, kind of not all of them are very well aware what they have right for, what is free, actually free and provided through the National Health Service, and what are the things that they should really contribute to and should pay. What is also not helping is kind of where there's a clause in the Constitution which says all healthcare is free. In reality, it is not. And it's kind of, while it's there, it's very difficult for the people just to really to come to very formal co-payments. So co-payment issue is still very highly politicized, and this is the area we probably need to work more with the government, with the politicians, but also with the audience and with the healthcare professionals. Over to you, Nata.
Thank you, Paola. Thank you. And I would like to ask the audience, don't be shy. Please post your questions. We look forward to hear from you, feedback, what are you interested in? So please post your questions in the Q&A format. So I will maybe explore further on our discussion. And one of the topics that was highlighted, Elizabeth, Vlad, everyone talked about, is that we know that reforms do not happen in isolation just in health sector. And in Ukraine in particular, since the revolution of dignity, there were comprehensive national reforms going in many sectors. And the decentralization reform is one of the biggest on the agenda, and it's still in the big process that is going on. So maybe I will ask Vlad to explore in this topic how that affected health sector reform and how the coordination happened, knowing how important is the decentralization in healthcare as well.
Thank you, Natha, for this question. Few words about decentralization reform. As I mentioned during the presentation, in parallel with the healthcare reform, the administrative structure of Ukraine is being reformed. Last year, Ukraine Parliament passed a law providing for the creation of new territorial association and large districts. Instead of 490 districts of different size, 130 enlarged districts were created. It was assumed that such enlarged district should cover at least 150,000 people and an area with a radius of 60 kilometers from the center of the district. This reform was led by the Ministry of Regional Development. And when we talk about the potential barriers that this reform can pose to health reform, we should talk about the importance of synchronizing them. If there is not such synchronization, it will hinder the development of networks of medical facilities. Since each institution belongs to the community, the lack coordination at the meso level, at regional level, can lead to wrong decisions because integrated healthcare provides for the extraterritorial principle, coordination and medical care and general medical space. These approaches make conflict with the vision of the individual community as the owner of the hospital, example. However, most communities cover a small population of 10 to 50,000 citizens, and the level of coverage of a modern acute care hospital starts from 150,000 and more. This means that communities should develop their institution not independently, but in cooperation with other communities, and to develop not separate hospitals, but their networks. This requires new knowledge and new tools. This requires time and technical assistance to communities. They need to be helped to move from competition to collaboration. The same applies to the national level. Different ministries that manage different reforms. The task of establishing cooperation and synchronizing activities is very important. The government understands this, and as we know, understanding is the beginning of solving the problem.
Thank you very much, Vlad. I just want to remind everyone that in order to post your question, you have to do this through the platform. So you have to access the Q&A box on the platform in order to be able to, in the portal, in order to be able to post your questions. There is no option for Zoom. So please access the portal. There is a Q&A box where you can put your questions. Please move fast. We have a few minutes left for this first part of our session. So maybe meanwhile, I will continue with some questions that I had myself, and I heard a lot from other colleagues in our earlier discussions. So we know that the major reform in Ukraine started with the health financing health financing system reform. And it's very common that health financing system triggers the large system-wide transformation. So there's been big results achieved with rapid implementation of capitation payment in primary healthcare and the launch of the case-based payments in hospital care. But it's still at the early stage. So what is next with the health financing reform? So maybe I'll ask Paola to explore on this topic.
Thank you, Nata. As probably kind of you've seen from the graph in the presentation, yes, we said that the health reform already started at the secondary level, at the level of the hospitals. But so far, in terms of health financing, they only kind of they moved to a very, very basic financing module, which is in global budget. And only now they gradually start introducing in case-based financing, which in quite small proportion. Only for the 4 priority services, they have 40% of their budget from the DRG. And this is the services for heart attacks, strokes, and neonatology. So the next steps in the health financing to start moving all the hospitals for all the nosologies to utilize the fee-for-service based on the DRG. DRG is quite new in Ukrainian system. So Ukrainian doctors are only kind of starting to learn the system through for example, the new way, the National Health Service online academy with the help of the project, with the help of a health reform support. And it's a really difficult difficult task for the doctors to get used to it, to use it properly. So these are the next stages for health financing to move to more sophisticated methods of health financing. And think about the next stage, think about the incentives for proper treatment, for quality treatment, and move to performance-based funding for the key performance indicators, which yet to be identified. And this requires additional kind of financing from the government, because this needs to be piloted, this needs to be developed. Over to you, Nata.
We are almost at time for this session, and guess we are soon going to move to our next topic. Very interesting. It's going to be talk about future of health systems. But maybe just one last thought. I think it's important to say that there is a lot ahead in the reforms in Ukraine. We wanted to talk about many other things and many challenges that are still ahead. One of the biggest opportunities that we see is that was already mentioned today is the private sector engagement. The private sector still has to play a big role in Ukraine, like globally. There is more and more, the private sector engagement becomes more and more important. And we see for the sustainability of healthcare systems, how important it is to develop partnerships with the private sector. So it has already been seen in Ukraine. So there is a lot of more opportunities in that. And we've seen that very interesting how COVID-19, originally we thought that the pandemic response is going to stop the reform implementation, but reform continued, and the pandemic response and challenges of the health system actually brought very important lessons learned to Ukraine to see where are gaps, where are challenges, how the public health system responded, how the public health system has to be transformed, and how the service delivery models have to develop in order to be more effective. So these are challenges ahead. The Ukraine has a long way to go, and hopefully this was interesting for other countries, other participants to know about this very comprehensive reform. So for the next one, for the next session, please stay tuned, stay with us, because we are moving to very interesting and cool discussion about future of health systems, like we call it in Deloitte, because we're going to present some very cool tools, very interesting accelerators, enablers that hopefully will make reform implementation easier. So, here I go, giving floor to Vera.
Thank you so much, Nata, and colleagues in Kiev. Thank you for a very interesting, thought-provoking session. What really resonated with me, and I think is things that we'll be touching upon in our subsequent session, are just how complex these reforms are when you're talking about an entire health system and working across the health system. And Elizabeth, you were talking about how there's a need to be adaptive while you're doing it. And, you know, I think the phrase you used was flying the plane as you're building it. Which just adds to that level of complexity and trying to make sense out of all that noise and out of all that change as it's happening in real time. What also resonated with me was Paula's comments about multi-stakeholder engagement and commitment. So when you're talking about bringing additional people along, that just makes things more complex. So that need for clarity and that need to get everybody to converge around what the best path forward is crucially important. So these are just touching upon some of the things that my colleagues and I will be sharing with you over the next hour. But welcome to the second session on the future of health systems. I'm Vera Zlidar from Deloitte Consulting, and I'm excited to share with you some of our thinking and perspectives on how we see data analytics as an accelerator and in a way positioning us to be able to work in the future of health systems. We see data as a way, real-time use of data and analytics as a way to improve health system performance, and therefore what we're all going after, which is improved population health outcomes. So the tools my colleagues will show you take a broader systems view of health. They do that by integrating different data sets outside of the health system. They do that by bringing in different perspectives from different players outside of the health system. And they use predictive analytics to knit together these data sets and better target how health system resources can be used. This is so that program managers and health system stewards can be more thoughtful about their investments, get more value for money out of their investments, but also in a way you can also start using these tools to be a little bit more forward-looking and do scenario planning and be more proactive for dealing with health system shocks that may come down the line. And I think COVID-19 is an excellent, unfortunately, real-life example of a way that this could be used. The way that we've structured the session is that we have 4 presenters who will come after me, and each of them will spend a little bit of time showing you their tool and how it's used. We'll follow that with 1 or 2 quick questions about what that tool looks like, how it's used, and then move on. We've saved the last 15 minutes or so of this session for your questions and answers. We're really interested in your perspectives, your insights, your comments on how you think this might be applicable to your context and your settings. So please, as Nata said, don't be shy. Use the chat box, not on Zoom, but on the actual conference platform. Put in your Q&As and we'd be more than happy to take them. So with that, I'll now introduce you to our first speaker, Dr. Lavan Srinarayanadas. He will talk about the DSmart tool. Lavan, over to you.
Thanks so much, Vera. So just as a level set, I will not have the fancy slides to begin with. You'll be listening to my beautiful voice, but bonus, you get live demos of DSmart. So with that, I'll start. In the early days of the pandemic, which now seem like a lifetime ago, we began building a model that could help spot future COVID outbreaks and inform decisions about closing schools or canceling sporting events. And as we were building that, we went into lockdown. So we had to quickly readjust. And what we later have learned, or now have learned, has been constant readjusting during the pandemic. We had to quickly shift from what are we going to need to close down to how do we reopen? And what seemed like, okay, a quick adjustment actually we started to realize was a much harder task. And the early models sometimes didn't work as expected, and we had to figure and troubleshoot all these different problems. So for example, large counties and small counties in the United States. The math to forecast transmission and fundamentally different, the difference between rural and large counties is actually quite large. And so we had to change the way we thought about risk for these different areas. So we went from a relative risk score to absolute risk numbers. And we'll get into what I mean by risk scoring a little bit later. We also encountered unanticipated data irregularity issues, and which were also compounded by uneven region by region reporting. So urban areas may report consistently, whereas rural areas may only do it very infrequently, every 2 days or 3 days. And so we had to constantly adjust for these kind of data irregularities. And now with almost a year now of daily recalibrations at a county level in the United States, as well as global recalibrations, we've created essentially a sim city of the entire United States as well as the globe. And we were able to predict transmission rates with enough accuracy to forecast the magnitude and direction of COVID infection rate. So what that means is in what direction it's going, up or down, so increasing or decreasing, and at what rate. So are we seeing large spikes or large decreases, or just kind of a small steady decrease or increase? And with that, we're able to also scenario plan. What do different interventions mean to the rate of increase or the direction in which the infection rate is going? And the simulator, this massive simulator, what it does is applies math and physics to the data that we collect and also that we predict. And so what we can do here is we layer in existing infection data, and then because our model exists outside of the data, we create these baseline estimates and we recalibrate according to what the data is showing us. So it acts essentially as analytically like a Bayesian model. The simulator generates a prior before reconciling the prediction with actuals. So we look at what our model is telling us, and then we bring in the COVID case data to then reconcile against that and then predict out. And I promise you the math will end eventually. What we've done with our model is we've created this SIR, susceptible, infected, recovered model, and combined it with an agent-based model. And it may seem a little weird to combine these two different types of models, but what we do with this is we use the SIR model to identify the types of players that are happening in this agent-based model. So whether they are susceptible to infection, whether they've recovered from an infection, and whether we are increasing distancing or not is done through the agent-based model. And so what we can do is take those outputs. So the COVID case data goes into the susceptible, infected, recovered. And then we put this into the sim city, and that gives us how these different players are interacting with each other. And that gives us a rate of transmission in those different areas. And then what we do is we bring in additional data like demographics, socioeconomic information, population density, which just get more and more accurate data into our agent-based model. Now, as I promised, I will go into an actual demo of the tool. So just bear with me 1 second. This is the DSmart tool. So what you're looking at here is the state of Texas. And what you see here are the colored squares are the different counties, and they represent our risk score. So our risk score, anything below 1 is a declining infection trend, and anything above 1 is an increasing infection rate. So what you will see is, you know, as many of you are from different countries, you're going to hear a lot about US infection rates being very, very high. And why county-based analysis is incredibly important is when you look at the US as a whole, yes, you're going to see massive infection rates compared to the rest of the world. But when you go down to a very granular level, you start to see that a lot of that is focused in certain counties, which is really incredibly important. Also, this risk score is a forward-looking metric. So what we're able to do is identify areas that are on the increasing infection trend and allow you to then target any kind of intervention, whether that is increased testing. Increased testing has a direct correlation with reduction in infection, because the more people you identify as infected, the more likely they are to start socially distancing and reducing the number of people out in public that are infected and spreading the infection. So what you can see here now is the breakdown of our risk score. So this is the risk score itself. And these are the different variables that go into the risk score. So transmission rate is the speed at which the infection is spreading. Percent infected, active infections, new COVID cases, these are active infections and percent infected are both lagging indicators. Change in influenza-like symptoms and COVID-like symptoms, as well as transmission rate, are leading indicators. And what I mean by that is, if you are testing someone and we are putting in data based on how you've been tested, that is not a forward-looking indicator of how the infection is going. It's telling you what the infection was like and what it's like right now. And so the really important data sets that we use to give us a forward-looking perspective on things are things like mobility and flu-like symptoms, which is a really important one because this is something that the US CDC has been tracking for years. And it's data that's publicly available. Like every other data set that we actually use in our model, it is publicly available. And it's something that I highly recommend when I talk to other government clients, that this is a metric that doesn't seem like it's something that would be useful for COVID or something that'd be useful in this situation, but it has been incredibly useful to our team in having us being able to predict and forecast where infection rates are going. Now, how we've adapted this model for vaccine rates and vaccine distribution is really important as well. What we've done here and what you can see here is we've created a very simple Tableau dashboard, and the only part of this that leverages our model is what we use for the number of potential active infections or percentage of people infected. So what you're seeing here is the US and its current vaccine trend. So we take the number of people that our model has predicted are actually infected, because as we all know, the number of people that are tested does not really equate to the number of infections that have actually happened in your country. And then we also take the vaccine rate. So currently the US is not as strong as some other countries in its vaccine rate, but we are projecting, this is a soft herd immunity target, and this is a hard herd immunity target. We are projecting that, you know, in October, November, we could see some herd immunity if the current rate keeps going. And we can do this for almost every country. So why don't we take a look at a country that has a very good vaccination rate. So you look at the difference now. At one point, Israel was doing 150,000 vaccinations a day. And this is tracking not vaccinations, but people vaccinated. So that I think that's a very important differentiator here. And you can see now that herd immunity is going to be reached a lot sooner for something, a country like Israel, because of their their vaccination rate, and also, you know, they have had quite a number of infections as well. I'm Canadian, so I like to look at Canada's every once in a while, and we can see that the vaccination rate, along with the percent infected, have a very low number, and the rate that they're vaccinating currently is quite low. And so you see that, you know, it's going to take a lot for Canada to start increasing and getting close to that herd immunity target. Thank you. Vera, I think we have some questions that you want to ask, but I don't want to take too much time on math. So.
Sure, thank you. Very interesting about all of the data that you're pulling into the model. So in some ways, we're fortunate in that we have strong health systems where we can acquire fresh data, quality data that is constantly or regularly updated without a lot of gaps. That's very different from the situation in most resource-constrained settings. So can you talk a little bit about, Lovan, the data quality issues and how this model can deal with the gaps that I was mentioning previously?
Sure, and I'd also like to caveat that, listen, there are certain parts of data that we get from government, and some of it is also through private industry, right? So private industry has made a lot of data free and available. Mobility data, for example, is accumulated from all of those those disclaimers that you check yes on for apps that you put on your phones. That's how we're getting our mobility data. But yes, I think every country has data irregularity issues. 4th of July weekend, right after that, we had massive spikes because nobody wanted to do anything right before 4th of July or the day after, right? So we have to deal with these data irregularities. And so what we've done is we do a lot of smoothing techniques on data that's being input into the model, but then we also have sanity checks on data. So if you are showcasing COVID infection rate that, or the number of infected much higher than the number of population in the county, we know that there's a data problem. And then because our risk score is an aggregate of a number of different metrics, what we're able to do is we weight all of these differently. And so if there are certain metrics that aren't available, we can then weight the others differently. And I think this is a really great kind of plug for how we actually built this model. It wasn't just with data scientists. And I think that's a really important fact here. We worked with, you know, epidemiologists like Rodri, who you'll be hearing from next, who's I like to joke around with him and say he's world famous, but he's very famous in Deloitte at least. And because Deloitte is around the world, ipso facto, he's world famous. But we got to work with some really amazing people, and taking a multidisciplinary approach to problem solving is, I think, the best way forward. And because we have all of this available to us at Deloitte, it just makes it easier for us to get these things out quickly.
Great. Thanks, Lovan. Everybody at every level of the health system has such a different responsibility, such a different focus, such a different approach to their work that multidisciplinary is incredibly important. Okay, let's move it over to Rodri Deers-Davies. He is going to show us a tool together with Smita Sharma called Health Prism. Rodri, over to you.
Hi, everyone. My name's Rodri Deers-Davies. I'm an epidemiologist and behavioral scientist with Deloitte. So I'm here to talk to you, and I'm also famous, according to Lovan. I'm here to talk about Health Prism. Next slide, please. So as we all know, health crises are not always monolithic events. They're dynamic, they're complex, they're very costly, and they're very socially connected. They not only involve individual health outcomes, but also include structural factors, regional infrastructure, local customs, societal inequalities, and governmental laws and policies. And each of these different sectors is really trying to answer some of the same kinds of questions. Who is at risk? Where do the inequalities exist? What are the barriers to treatment? What are the optimal interventions and where are they best targeted? And what is the role of the individual versus the health service versus the government agency in helping solve these issues? To address these questions, Deloitte has created the Health Prism database. The goal of Health Prism is to help gain sort of insights, focus resources, and most importantly, protect lives by using publicly available data in unique ways that's focused on improving population health and also strengthening health systems and infrastructures. Next slide, please. Health Prism is a US-based proprietary tool that compiles multiple disparate data sources at sort of household, community, local, and national levels. From this, our team is able to create unique variables focused on generating estimates for individual level and community level health incidences or disease incidents. We can also do risk predictors for specific conditions. We can address impacts of social determinants of health on outcomes, generate behavioral archetypes for messaging purposes, and gain individual and community sentiments on specific topics of interest. Models are built in a variety of ways, such as we use machine learning algorithms. Some of them are regression-based, and there's also some AI involved in obtaining risk scores and health indicators for specific conditions and outcomes. There are several examples of this that we have used in the real world. For several of our US federal and state government clients, we've helped expand vaccination opportunities and equip influential parties to support flu vaccination and education delivery among sort of disparate racial and ethnic minority communities and other vulnerable populations, investigated the use of augmented risk modeling to successfully improve the probability that individual packages through the mail that may contain illicit substances can be better identified and then diverted. And we have used it to help build opiate data analytics platforms to integrate multiple disparate data sets like claims data, child welfare data, records keeping, medical exams that can better coordinate care for patients. From an international perspective, we have actually worked with many local firms in different countries to acquire similar databases to sort of solve health and human services problems in countries such as Mexico, Brazil, Canada, France, Japan, and China. So this is a fairly robust, large data set that we have helped other countries develop. Now, what I'd like to do is give everyone sort of an example of this. I'm going to turn it over to my colleague Smita, who's going to present a demonstration on how Health Prism can be used to investigate diabetes in Los Angeles County, California.
Awesome, thanks, Rodri. So before we get into the actual demo of Health Prism, I just want to take a minute here to orient everyone on examples of how we can use our social determinants of health information in order to inform risk scores for certain personas and certain health conditions. So the example that we're looking at here, we have two personas and we're simply just looking at the medical information. With only looking at medical information, we see these personas have similar histories and therefore similar risk factors with 15% and 13%. But then when we start to add in social determinants of health information and financial information, we get a more wholesome picture, a whole 360 view of both personas. So when we look at activity levels and whether populations are homeowners, their family situations and things like that, we can see that Persona A's risk score has decreased 5-fold to 3%, and Persona B's risk score has increased 45%. So keeping that in mind, I'll now head over to the demo. And as Rodri mentioned, this is the front end of our Health Prism platform. We have millions of data points loaded in on the back end, but right now we're just focused in on California's 26.5 million adult population. But with that, we also have data loaded in ready to go on all 50 states as well. On the right-hand side is the list of all of our health condition models. For this example, we will just be focusing in on diabetes as the primary health condition, but we could look at other chronic conditions like asthma, back pain, obesity, cardiovascular disease, hypertension. We have models on various cancers and then can also look at drug-related conditions like substance use disorder as well. Over here on the left-hand side are two examples of unique models that we've built for Health Prism. So this first one here is the risk percentile score. And what this allows us to do is increase risk scores in order to focus in on populations who are in the top 10th or 20th percentile of risk for that certain health condition. And then that bottom score, there's an influence score, and that allows us to understand what characteristics within our population we are likely able to influence. So that really gets behind the reason why a population may be at risk and what their barriers to treatment are and how we can potentially positively influence or change those barriers. On top of these risk scores, we can also look at social determinants of health variables. So this is what you're seeing here. We have about 50 just on this front end here and thousands in the back end. This first category here is household indicators. This allows us to understand household composition, or we can look at housing insecurity related variables like household debt. Scrolling down a little bit, we have financial indicators. Here we can look at income level, net worth, risk of unemployment of a population. Beneath that, we have several health indicators. More recently, we've started to look at COVID-19 risk indexes. We've also can cut our population into potential vaccine category groups. Within our individual indicators, we have some demographic variables like age, race, gender. And then lastly, within our geographic indicators, we can look at our population based on county, city, zip code. And here I've selected closest distance to a hospital and urgent care facility. And that helps us start to realize where potential food deserts, if we selected grocery store, or medical deserts are located within our population as well as across the state. So now we're going to come here and refine our criteria further. So in this example, I want to focus in on low-income communities of color who are several miles away from a hospital or urgent care facility. So that's what you're seeing being selected here. And simultaneously, you can also see how our numbers at the top continue to get more focused. And now we'll get to a population of about 7,000, and our starting point was 25 million. And then from here, over this heat map, you'll see a bunch of dots pop up, and each of these dots represent the 7,000 population that falls within this refined criteria that we've selected for. So low-income communities of color who are 2 or more miles away from a hospital or urgent care. And then in addition to that, to better understand and visualize where these food deserts really are, we can overlay the population with points of interest like hospitals or urgent care facilities. And so that's what you will see, the green dots and blue dots pop up. And so that's where we're able to better understand where populations are relative to these points of interest.
I'd just like to pause it here for a second, actually.
Sure.
I think it's very interesting to see, before we scroll in too deeply, that there are a lot of parts of the state where there are a lot of clusters of individuals who are far away from a medical facility. So, and we felt that Los Angeles County had sort of the richest example of that, which is why we're going to focus on that next.
Awesome. Yep. So we can from here start to zoom into a population of interest where we're seeing dense clusters, just like we're seeing here. And Rodri, do you want to talk more about your experiences and this visual here?
Sure. So just for a little background, I spent 7 years as an epidemiologist for the Los Angeles County Department of Public Health. As you can see, there's a certain amount of red clusters sort of just below downtown in the southwest, where it says Los Angeles. That's basically downtown. And this is an area or a region that is sort of historically known to have poor medical care, a poor proportion of medical care services for the amount of population that lives there. So they have some of the lowest hospital bed to patient ratios in the entire United States. And as you can see, we have two major clusters in Southwest Los Angeles, where there's a lot of patients or households that potentially have patients which might be in need of diabetes services that don't live very close to a medical facility. And this is sort of a perfect graphical example of what sort of a medical desert looks like. So if you want to scroll in a little bit more, from a health systems perspective, this is a good way of sort of identifying where individuals live versus where health centers are and where new facilities may need to be developed in order to serve the populations that are at greatest risk. Now, this isn't one example for people at high risk for diabetes who are members of minority populations and low income. This can be done obviously for clusters of diseases or conditions. This can be done for other parts of the population, but it really gives, I think, individuals a really nice sense of where one service is versus where the people are and where things from a structural perspective may need to be improved. So we can move on. So next slide. So what we sort of wanted to do with this slide was to sort of show, we understand this is a US-based tool, but we wanted to sort of peek under the hood a little bit and get a sense of what, if another country was to develop something like this, what are the kinds of materials or data that folks would need? Health Prism, I would say can offer a good roadmap for governments and agencies to build their own sort of, way of looking at this data itself. And you can see that we use a lot of disparate data sources that are all publicly available, I might add. So you can see there is consumer data, publicly available data, insurance data, and marketing data that's involved. This tool can be used to generate unique scoring mechanisms, as we've sort of shown. You can build sort of personas for marketing and strategic communication purposes. You can identify service gaps or areas for growth, like we just did in our example, and also help conduct sort of systematic assessments very quickly to support sort of policy recommendations so that you can strengthen systems and also strengthen the health of your citizenry. So you can go to the next slide, and that's our talk.
Wonderful. Thank you so much, Smita and Rodri. Yeah, a little bit earlier while you were talking, you mentioned something about public health messaging. And so we know it's incredibly important to drive demand and nudge folks to access healthcare services, adopt healthy behaviors. Can you tell me a little bit about how this sort of a tool might be used for such public health messaging?
Yeah, I mean, this tool has in it the ability to sort of identify behavioral archetypes, people who may be more accepting of certain messages versus another, and it can also identify where people, as we've seen with certain health conditions, can live. But public health messaging and marketing has always been in my experience, sometimes it can be very difficult to identify the patients at risk, especially if you're dealing with a condition that might be sort of stigmatized. So creating behavioral personas and also identifying populations and groups at risk can really help you target appropriate messages to people. Some people may be ready to engage in a new behavior, so you can identify a certain message for them and push that. Other people might need more of an education approach. And I think tools that we've developed, which are ingrained into Health Prism, can actually do that very effectively for different populations and different groups. We also at Deloitte have a pretty robust behavioral insights practice where we work with different government agencies to create sort of nudge messaging. And I think with that approach mixed with something with Health Prism where you can identify where the persons who are appropriate for certain nudges actually are, can make your messaging campaign very robust. I would also mention that public health messaging and advertising is expensive, and there's not always the budgets to support it. So anything or any tool you can do to help target messaging to the right people is going to have better outcomes for your population.
Absolutely. Great point, Rodri. And then can you tell us a little bit about how you are using and have used this tool in the past?
So we don't want to go into specifics, but I will say we've been, Smita, do you want to talk a little bit about, I know we're working with a state in the United States to work on vaccine distribution for COVID-19. And I can say in that one, what we've done is we've actually kind of identified behavioral archetypes around vaccine hesitancy, and we're using that to sort of identify or develop messaging and develop public health responses, which deal with person's different rationale for why they might be hesitant to get a vaccine. I think we're finding some populations think that they're not going to get it. Other populations are actually afraid to report it because they are the main breadwinners in the family, and they're considered essential workers. And if they were to find out that they were positive, that they would basically be sent home and not be able to work. So we're using that to sort of identify these different risk groups and then target vaccine and also testing information to them. Smita, do you have anything to add to that?
Yeah, sorry about that. I started talking and then I realized I was on mute, of course. But yeah, just to add to that, definitely working with various states, especially around, you know, we've worked to combat the opiate epidemic with several states, and then more recently focused our efforts around health equity. And just to reiterate what Rodri has already said, but you know, things like that, project outcomes look like prioritizing counties in order to, you know, maximize access for the most vulnerable populations, identify who's at risk for vaccine hesitancy, and then using those behavioral analytics and nudges to reach out to those individuals, and then also providing insight into the impact of COVID based on race and ethnicity and other social determinant of health characteristics that you all saw in the demo. And then also being able to inform where, you know, points of interest like medical facilities or hospital systems are and where gaps in coverage may lie, and kind of helping to strategize that.
Yeah, I would just add, you know, obviously we've shown that due to the richness of the data set, we can tailor it to tackle a variety of sort of public health issues and emerging crises, and give unique insights into how to potentially solve them.
Great. Thank you so much, Smita and Rodri. I love that you ended with equity. You know, it's a foundational to universal health coverage and what the world is marching toward, and ensuring that it's equitable, healthcare access, quality of care, et cetera. So really glad to hear about the strong focus of that, and the social determinants of health absolutely lend themselves well to that as well. Okay, so we'll move on to our next speaker and our next demonstration. We had a clinician, an epidemiologist, and now we'll have a core public health person who studies and works in health systems day in and day out, and she'll talk about her perspective with this tool called Mission Graph. Elizabeth Hinchy, excuse me, over to you.
Thank you, Vera. So my name's Betsy, and as Vera mentioned, this tool will introduce, this presentation will introduce a tool called Mission Graph. As Lavin and Rodri have emphasized in these past two presentations, to strengthen health systems, we need to make decisions informed by data. But there's a lot of data out there: health data, socio-demographic data, data from other sectors like education, finance, food security, transportation, many sectors, players, and indicators that could impact our health systems and our decisions about how to strengthen them. Now imagine that with a few clicks, we could synthesize all of this data and visualize it in a way that enables us to uncover insights rapidly. This is what Mission Graph's all about. I'm going to take a step back and consider the problem with you. So in health system strengthening efforts, we're facing complex questions that cut across different levels and actors within the health system, and that are also affected by factors outside of the health system. To answer these questions, we face many hurdles in analyzing the data available to us. Data sets are siloed and massive. They are also disorganized, requiring tedious data cleaning and a lot of back and forth with IT. And it's a time-consuming process, one that doesn't allow for the discovery of advanced, actionable insights in a rapid manner. One example here is a question that we might encounter in Malawi. How can we better utilize and coordinate resources, institutions, partners, and programs to lower the HIV prevalence among pregnant women? We know that there's a lot of data on the health system in Malawi, on HIV prevalence, and on all of the partners and programs intervening. but it's difficult to bring all of this data from disparate sources together and glean insights into how to adjust HIV programs or the health system to reduce the HIV burden. And most importantly, we need to answer this question in near real time so that we can provide agile adjustments to the programs, interventions, and health system components. So how can we do this? One approach to consider is Mission Graph. Mission Graph is an innovative self-service platform for massive scale data analysis. Data from multiple sources can feed into Mission Graph, which consolidates and integrates the data. The platform then uses graph technology to connect data points and map relationships. The user can then run customized algorithms to visualize these relationships and patterns, enabling them to gain new knowledge about the topic area. That new knowledge is then used to further customize the platform with machine learning so that the algorithms improve and become more useful for decision-making over time. Putting it back into context with our Malawi example, we've compiled data from 4 publicly available data sources: the DHS, PEPFAR, Feed the Future program, and the Humanitarian Data Exchange. And this is how it works. Mission Graph consolidates the data and connects information about entities. So for instance, if I have multiple sources of information about a district in Malawi, all that information is connected together and grouped by district. The same is true for other entities, such as healthcare facilities or program partners. Then the tool graphs relationships so that we can quickly visualize how different entities, like districts and partners, connect. As new data is loaded into Mission Graph, the map of relationships grows, and users can interact with this map to explore the data, ask questions, and gain actionable insights. So now I'll show you what it looks like. In this dummy data set, we've selected the district of Mangochi, Malawi. This initial view shows all of the variables connected to this district. And if we right-click the Mangochi bubble, we can see key socio-demographic characteristics and indicators for the district. This data is compiled from our 4 data sources. We have selected HIV prevalence among pregnant women as a key performance indicator for the district. Just by looking at the icon, we can see how the district is performing with the yellow ring around the bubble, indicating that the HIV prevalence is not great. We can reprogram the icon to represent any interesting data point or performance measure that we've compiled. We can then expand the view to look at all the connections to the district. Each bubble represents a different entity or data variable. And as you see when this loads, there's a lot of data here. But we can zoom in and out to get a more detailed view of any part of the graph. Now I'll quickly collapse this view and change the depth of connections to 2 for a more manageable view. And again, if I were to right-click on any of these bubbles, I could see more information on that entity. For now though, I'm just looking at how the different entities connect and the relationships between them. With a few clicks, I can organize a graph in different ways. And to make sense of all this data, we may run an algorithm to ask a specific question. For instance, I may want to figure out why the HIV prevalence rate is so high in Mangochi. I'll run an algorithm to ask this question. Then this algorithm we've programmed to see similar districts that are performing better than Mangochi. You can ask all sorts of questions and add algorithms here so that with one click, you can draw quick comparisons and highlight connections like we have here. My algorithm instantly finds Nchu, a district with similar socio-demographic and epidemiological indicators, but that performs much better than Mangochi in lowering the HIV prevalence rate among pregnant women. I can click into the info of each district to see some differences like the % uneducated women or the counseling rate, which may help to explain the performance. But now for another view, I'm running the algorithm again and expanding the connections for the 2 compared districts to see what nodes exist and the relationships among them. Right away, I see the 2 districts have one shared connection, a partner that works in both districts. But after I expand each district, I can see that I can see all the other connections that each district has. I can also filter out certain entities to see only those that we're interested in. In this instance, I'm showing only partners. One of the things I might notice here after filtering is that Mangochi has more partners, 11 versus 4 in Enshu, which could indicate more fragmented efforts. I could follow up with the shared partner to learn more about this. And while these insights may not answer my question outright about why Enshu is performing better than Mangochi, they point me in the right direction and give me areas to explore. So the tool I just showed you looks relatively simple, I hope, which of course is part of its appeal, but the potential for health system stewards is massive. With a 360-degree view of all the available data about a health system and the ability to quickly explore complex relationships in a visual manner, we can gain new knowledge for rapid data-driven decisions on an ongoing basis. This enables us to improve health programs and systems at the national, regional, and local levels. In our hypothetical Malawi example, after exploring further and contacting the shared partner, we may identify an intervention in Enshu that was missing from Mangochi. And by better coordinating partners in Mangochi, perhaps we can reduce duplicative efforts and reassign resources to apply the new intervention. As a result, HIV prevalence rates among pregnant women could decline. But again, this is just one example. Mission Graph could be used to help us gain insights related to all sorts of global health challenges and health system strengthening efforts, like the managing of the health supply chain, planning healthcare facility and workforce distribution, identifying high-risk groups for targeted interventions, and many more. So with that, I will open it up now for some questions.
Great, thank you so much, Betsy. I'm struck at how you're able to take all that messiness and that complexity and really distill it down into an insight that is actionable and useful for program managers and health system stewards. So thank you for that. One question that I had for you as you were working through the demo is, how is this tool different from other data analysis and data visualization tools that folks currently use, such as Power BI or Tableau or Excel?
Mm-hmm. Great question, Vera. So there are a lot of tools out there that synthesize, analyze, and visualize data, like Mission Graph. But the appeal of Mission Graph is that it's a self-service platform. And what this means is that the user doesn't need to know R or Python or other coding language. They don't need to go back and forth with an IT department who knows how to use the particular program. Rather, the user could be a health system expert or a program decision maker, and they could hold that power of data analysis in their own hands, which of course lets them make decisions more quickly, lets them run algorithms to ask questions, learn from those, and again, continue that feedback loop in a very rapid manner to get insights to answer their questions, or again, at least point them in the right direction to help them answer their questions.
Great, thank you. And I'd be interested in your thoughts, since you work in the global health context, how something like this might be more broadly applicable or used within global health.
Sure, so I threw some examples on this slide, but there's two here that I'd love to highlight. The first is the planning and distribution of healthcare facilities, the health workforce, and really health resources in general. Because Mission Graph can quickly identify areas of greatest need or high risk, the tool enables us to better plan health system resources in the short, medium, and long term. So for instance, with COVID, we could identify healthcare facilities that need surge support. Or in the long term, we could plan the distribution of health workers, such as doctors, nurses, even mental health workers or social workers, based off of demographic data, disease burden data, geographic data, a slew of other variables that we'd bring together to make projections. And then one other example I want to highlight here is the coordination of all of the different health system players. I know this was something that was brought up in the earlier section on Ukraine as well, and it's a problem that we see again and again in global health, a challenge that we try to overcome as we work with government, donors, implementing partners, NGOs, private sector, civil society, the list goes on. And there's no single source of information about all of these players in the same tool, in the same visual for us to digest. So with Mission Graph, all of this information could be synthesized and visualized so that we could better coordinate resources and reduce duplication and increase efficiency in the health system.
Great, thank you so much, Betsy. Very interesting approach to using data in analytics. At this juncture, I'd like to invite Lavan and Rodri and Smita back for a little bit of an extended dialogue and Q&A. And the first question that I'd like to pose, maybe I'll start with you, Lavan, since we've had conversations about this and before.
Sure.
Talk to me a little bit about privacy and data privacy considerations. All of the tools that we're looking at deal with so much data at the individual level, at the household level, and beyond. So share with me a little bit of your thoughts about privacy considerations for these tools.
Yeah, I think it's a privacy and equity consideration, right? So right now we're talking about, in the US, we have private institutions collecting all this data as well as public, and we're making it publicly available, which has been great, but the countries that don't have that data infrastructure or don't have that private investment haven't been able to do the same kind of thing. So it's been very hard to target COVID investments or COVID strategies, right? And that's something that we need to be aware of. But how do we do this while still maintaining privacy and equitability of data rights is a really important conversation that needs to be had. DSmart does it at a very aggregated level. We don't get down to the individual level. And I think that that kind of limits our kind of privacy perspective for the DSmart tool. And because we work with governments as well as clients, we use some of their data if needed, but everything we use is publicly available. And I think there's a broader question of COVID has brought to light the benefits of sharing data at a global level across borders and for very specific needs. Now, how do we translate that to reform in health systems and how we collect data? And also, how do we go forward and make this an ethical and equitable thing so that this data isn't misused and also exploited? I think one of the things you'll find is it's been very hard for us to deal with small counties because data irregularity issues are specifically for small counties. And that's not so much that's more of a resource constraint. Internet, cell phones, those kind of things aren't really as used as much in those areas. So I think those are the kind of questions that we keep coming back to. But the US has been lucky that private industry has really stepped up and done a lot of data collecting for us and made it publicly available as well.
So Vera, I'm going to chime in on that as well. I think I would have a more cautionary tone to that. Well, I think this data set is great, and I think we're showing sort of the positive uses of publicly available data here. I think everyone listening to this knows that that's not always necessarily everyone's point of using the data or purpose. I think we as a global society have to start dealing with the idea that there is not really a distinction between what we consider to be protected health information as being this needing extra precautions, such as IRBs and things like that, and what we used to consider benign data, which is like marketing data and data related to, how many clicks you do on an app or likes on Facebook or something like that. That, I think we've shown through all of these tools that we can take publicly available data and say very interesting and very detailed things about an individual or potentially even a household in a way that I don't think anyone ever envisioned. And I think regions like the European Union are really struggling with this right now about, how much of your data should be private or should all of it be private. And I think that as a global society, I think we have to recognize that data is no longer benign, that every time you walk down the street and your cell phone tracks you and you update something, or you go to the grocery store, all of that data is being used and compiled about you to either try to sell you something or do something else with it that you might not necessarily be happy with. And this distinction between protected health information, meaning medical health information, being important, and then everything else being not as important, I think is getting it's starting to pass. I think we need to deal with this directly.
Yes, absolutely, Rodri. I'm hearing the need for very strong governance, which is core and foundational to health system steward and what health system stewards do. So thank you for that perspective. I was very struck with what Smita was showing with the two personas or the two individuals, and how initially they had very similar risk scores when you were looking at core health data. But once you opened up the aperture and you started bringing in additional data sources to round out the view of that individual, those risk scores changed significantly. But then there's the cost benefit that comes with bringing in additional data so that you are able to refine, those risk scores and those perspectives. And I'd be interested in hearing your thoughts. Betsy, maybe I'll start with you on the cost benefit analysis of, sticking with the core data that maybe some of us are more comfortable with within the health system and the actionable information you get from that versus expanding the data set a little bit more broadly, maybe with certain variables and characteristics you're not necessarily comfortable with, but that will allow you to better target the populations that are at need. Talk to me a little bit about the trade-offs between those approaches.
Great question, Vera. And, there's no easy answer here. I think this was one of the lessons learned that Elizabeth highlighted in our session on Ukraine as well, that there's this balance between having enough data to have truly accurate decisions informed in the greatest possible way, and the speed of implementation. Ukraine's a great example because health reforms are moving very rapidly. And so you have to weigh this, how do I move quickly while also being able to adapt and learn from my efforts and collect data simultaneously in real time to inform future moves. I think that that's part of the appeal of some of these tools. So although they, are a bit of a jump for somebody to start using a new tool. It's a new way, it's a behavior change, it's an investment. They allow you to move quickly with data-driven decisions. So allow you to get data to inform decisions rather than the old ways of how we've been collecting data and going back and forth with IT and taking a longer process to make those inform our actions. So I guess it all depends on how quickly you want to move. What resources are available to you in the context that you're working in, the country that you're working in.
Thanks, Betsy. What stands out to me is you didn't come out and say this, but to me, you landed on, the benefits outweigh the investment because you are able to be more nimble, more responsive, and do things in near real time. Rodri, I see you've unmuted your mic. Did you have something to add?
Yeah, I was just going to sort of second that in the sense of, we talk about this with clients all the time. They sort of say, well, how much time and effort is it going to be to create this thing? And we're like, well, it's going to take some effort up front to create it. But then on the back end, I look at this as very simply almost like an automated report. So somebody spends an hour a week putting a report together, and they've been doing that for multiple years. And you come in and you go, well, if you give me 2 weeks, I can automate this. And then it's literally a push button that goes out overnight on Sunday, and no one ever has to work on it again. And for some people that can be something they're not used to thinking through. But I think for most of these tools, we've shown that they can actually accelerate processes and make, as Betsy said, help make decisions faster, which are always going to be worth the upfront costs you're going to have to get the system to do what you want it to do, and then it will help guide decisions faster as you go forward. I think there's always a benefit, especially in this time of COVID we're seeing where decisions have to be made quickly and accurately.
Great. Thanks so much, Rodri. There's also an element of self-service, and once that certain things and algorithms are built into it, you're able to play with those things, adjust those things as your needs evolve and as the population health needs change, so that you're able to sort of stay on top of that. So I think that that's also an element that tips the scales and the balance of the investment being worth the cost. We're almost at time, so I really want to thank all of the panelists here, as well as, again, our colleagues from Ukraine for a really interesting discussion. I hope that the audience found it interesting and was able to take away some of the sort of pearls that were left with me. I think making sense, finding clarity within that complexity is important. I started my public health career where there weren't a lot of data that we could use for decision making, and we got them every 5 years or so with nationally representative sample surveys, and now it's completely different. There's an ocean of data, and it's trying to find what matters and connect those data sets together to understand what you can do to help improve health systems and population health. And I hope that you've taken a little bit of our perspective of how data can be an accelerator to improve access, to improve equity, to improve quality, and essentially the impact of how you invest your resources as program managers, as health system stewards, and as implementers. So thank you so much for your participation. If you have any questions, our contact information is here, and we would love to hear from you. But thank you again, everyone, for your time and sharing your insights today. Have a great day, everyone. Bye-bye.